for what is happening.
We are
Madam,
live now, ma'am.
I called Arun. I think sir is busy. He'll join in a while.
Yeah, MG sir has become dean of that new college, sir. He's extremely busy now. Very difficult to get
we
on
can
our
go
webinars.
live and please start the proceedings.
Yeah, so we can start, and I think sir will join.
Yes, ma'am. Good evening, faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, episode 16 of AMOGS Emergency Obstetrics Committee with KSOGA. So it's my privilege to introduce the MOC and the coordinator of today's webinar, Dr. Sonia ma'am. Ma'am is the secretary of KSOGA. Advisor Safe Motherhood Committee KSOGA 23 to 25. Advisor Breast Imaging Committee KSOGA 23 to 25. I welcome you, ma'am. And it's my privilege to introduce Dr. Anita ma'am. Ma'am is the assistant professor at MR Medical College, Kalaburgi, treasurer of Gulbarga Obstetrics and Gynecology Society from 22 to 23, secretary of Gulbarga OBGYN Society from 23 to 24. I welcome you, ma'am, and I hand over the session to you.
Good evening, everyone. I am Dr. Anita Gaurak Kunin. I am working as assistant professor in Madhavaparampuram Medical College, and I will be taking over from here. I welcome everyone for today's webinar. To begin with the program, I will request Sahiti, please. Hello.
Yeah, you're
Hello?
audible. You're audible, Dr.
Yeah,
Anita.
I request Sahiti to start today's webinar with welcome lamp lighting video.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं
Is somebody speaking?
Yeah, Dr. Anita.
I request
ma'am.
Anita ma'am to please introduce Sneha ma'am.
We can
I
skip
welcome
that.
all the I welcome everyone to today's evening webinars. After a long weekend and a busy Monday morning, we are here to make our Monday evening also busy. So to begin with today's program, so before we start for tomorrow's election, we'll have a wonderful scientific session. I welcome the KSOGA office bearers, Dr. MG Hiremat sir, Chief Patron KSOGA. I welcome Dr. H. Nagaraj sir, Patron KSOGA. I welcome Dr. Bharti Rashekar ma'am, President KSOGA. I also welcome yes, ma'am. I also welcome Dr. Vidyathabi ma'am, past President KSOGA. I welcome Dr. Rajashri Paladin ma'am, General Secretary KSOGA. I welcome Dr. Suman Gaddi ma'am, Honorable Treasurer KSOGA, and Dr. Durgadas Arsana sir, President-elect KSOGA. I also welcome all the AMOGS office bearers, Dr. Kiran Fukoti sir, President AMOGS, Dr. Bipin Pandit sir, Secretary General AMOGS, Dr. Rajendra Singh Pardeshi sir, IPP AMOGS, Dr. Madhuri Treasurer Madhuri ma'am, Treasurer AMOGS, Dr. Sneha Bhuyan ma'am, AMOGS Chairperson Emergency Obstetric Committee. I welcome today's chief guest, Dr. M.G. Hiremat sir and Dr. C.N. Purandare sir, who's past President FIGO and FOXY. I also welcome today's guest of honor, Dr. Suvarna S. Khadalikar, President MOGS and Deputy Secretary General FOXY, and Dr. Madhuri Patel ma'am, Secretary General FOXY. I welcome today's speaker, Dr. Uma Deshmukh ma'am, and all the panelists for today's event. Moving on, Sahiti, can you please display Dr. Sneha ma'am's introduction?
Yeah, it's okay. We can skip that. A very good evening, everyone. Saiti, you can stop sharing. A very good evening, everyone. I would not spend much time in my introduction. In fact, just Dr. Sneha Buyar, your candidate for Vice President Foxy. Very good evening to all of you, and my respect and regards to respected Dr. C.N. Purandare sir, who is the chief guest today, and Madam Suvarna Khadilkar and Madam Madhuri Patel, who are the guests of honor. I welcome the entire team of office bearers of AMOGS and KSOGA. The president of KSOGA, the patron of KSOGA, Dr. M.G. Remat sir, Dr. H. Nagaraj, of course, the president of KSOGA, Dr. Bharti Rajsegar, and Secretary Rajeshri Palladi, the immediate past president of KSOGA, Dr. Vidya Tobi, our dear friend, and of course, Dr. Suman Gaddi, the treasurer. Dr. Kiran Kurtakoti, the president of AMOGS, Dr. Bipin Pandit, secretary, Dr. Madhuri Mehndar, the treasurer, and of course our respected Dr. Rajendra Singh Pardesi, the immediate past president of AMOGS, national coordinator Dr. Parag Biniwale. On behalf of the entire team of AMOGS, I welcome all of you. And I just take this opportunity to say that this committee has been working on last 2 years. I was working for medical disorders committee, and this year we are working for the emergency obstetrics committee with the very aim of reducing maternal mortality, and we are trying to make it the topics very practical, useful to the members in day-to-day practice. So today's actually topic what I have selected is the antepartum interventions to improve the perinatal outcome. And of course, it's not only the maternal mortality and morbidity, but also the perinatal morbidity and mortality. That is what our focus is. And the panel discussion, of course, is on hypertensive disorders of pregnancy. I would just say that it's not all of a sudden, though obstetrics is unpredictable. You do have certain predictive factors, and of course, the test for screening and early detection. So I think all of us should follow the proper antenatal care guidelines, and of course, we should be able to detect the abnormalities at the earliest. We should take the measures to prevent an early diagnosis and treat. So with this, I take this opportunity to have your blessings also. And I request Sahiti to display Sir's CV. I would not take much time. I would just say, Sir is the most respected personality we all should be proud of. Past president of FIGO and past president of FOXY. And of course, even today, practicing as senior consultant obstetrician and gynecologist in Mumbai. And sir has got lots and lots of accolades. I'm sure this slide is not sufficient, but we are, very fortunate to have sir's blessings and guidance today. So indeed, we would like to hear from you, sir. So over to you, respected sir. Purandare, sir.
Thank you very much, Sneha, and thank you for inviting me here for the webinar. And I must say you've chosen a very good topic. That it's important that the obstetrician should be aware of all this, especially the hypertension disorders of pregnancy and early detection. When you're talking about ultrasound now with the flow in the uterine arteries and so on. A lot of information is given to us well in advance to make sure that you give the medication to the patient to avoid complications that can arise from hypertension disorder. So I think I'm missing M.G. Hiremat. I wanted to see him very much because I haven't seen him for a while in the last couple of years, and would have been nice to see him. But unfortunately, Sneha, I can't continue for more than 5 to 10 minutes because I have some guests in the house, foreigners who have come, and I will have to leave you very soon. But I wish you all the very best, and it's a great opportunity for various societies, your AMOGS and the Karnataka State OBGYN Society to join together to impart knowledge and enlighten everybody. Thank you very much.
Thank you so much, sir. Thank you so much for your blessings. In fact, Dr. M.G. Hiremat, sir, He's very much there for every program. Today, unfortunately, he could not join, and for his convenience, in fact, we decided to organize this program at 8 p.m. But I think sir will join soon. Thank you so much for taking out time for us from your busy schedule, sir, and thank you for your blessings. Thank you.
Thank you very much, sir.
I take this
Thank you.
opportunity to invite guest of honor, Dr. Suvarna Khadilkar. Saiti, can you display the CV? At present, I would just say that Madam is the president of Mumbai Obstetrics Society and, of course, the Deputy Secretary General of FOXI. She is the professor and head of Obstetrics, consultant endocrinologist and gynecologist at Bombay Hospital. And of course, yes, I'm going to stop, madam. You can stop sharing, Sahiti. A very easily approachable and very considerate person, inclusive person, I would say, madam. Looking forward to listen to you.
Actually, at the outset, I want to say that it's my great honor that I'm here today with Dr. C.N. Purandare, who has been my mentor, and not only my mentor, but to mentor to so many of us who have joined today. And he always wishes well for everybody. So I thank you for inviting me here, and I'm happy that last time I missed this when sir was perhaps not there. So I take this chance that sir is here and I'm here. Now,
Madam, sir was very much there, and sir, all of us.
Last time he was there? Okay,
Yes.
sorry.
Yes, yes.
I missed you, sir, last time. We were at Palghar conducting the camp that time. So, Sneha, in the beginning, I want to congratulate you for your efforts that you put in anything that you do. It is with great dedication. And particularly, as sir said, today's topic that is chosen, the obstetrics and emergencies and high risk pregnancies, and then hypertensive disorders of pregnancy are very, very important for, whichever workshop, whichever obstetric conference you see, there will be a long session on hypertensive disorders of pregnancy, because in spite of having identified the disease, we have not identified the cause still. So we are still fighting to know the cause, because the moment we know the cause, we'll be able to conquer this disease, which we are fighting for so many years. And I congratulate AMOGS as well as KSOGA. I can see my dear friend Vidya, immediate past president of KSOGA, current president of KSOGA, Dr. Bharati. Am I right? Yeah,
Yes.
Dr. Bharati, you are also doing a lot of work. I congratulate you for the work. Dr. Hiremet, as sir said, I'm missing him. We have worked together on FOXI in various capacities. Dr. Nagaraj and Dr. Rajeshri Paladi, Dr. Suman, Dr. Durgadas, all of you at KSOGA are doing brilliant work. I missed your KSOGA conference last time, Vidya, when you, I think, installed, and when you came over also. Both times I could not be there.
Yes.
And I also really appreciate AMOGS President Dr. Kiran Kuttukoti, who is really going, across the state to do excellent work. And he's very, very enthusiastic, very active in all fronts. Dr. Bipin and Dr. Pardesi, who is already logged in here. Dr. Pardesi, you have been really, really very, very, I always see he's very sincere, and he is very proactive in whatever he is doing. So, Dr. Pardesi, nice to have you here. And Sneha, what to say, you have been working. So, thank you so much for having me here. And as sir said, even I will have to log out after a few minutes. I have a simultaneous another teaching program going on of my department, so that I can't miss. So I will have to log out, but I will be there, of course, coming. And wish you all the best. I'm sure you're going to enjoy the speaker, who's really, I think she is a president of Bidder Society, who is talking, Dr. Uma Deshmukh. So I wish you all happy learning, and I'm sure the panel discussion is going to be very interesting. Thank you so much. and have a nice.
Thank you, Suvarna, for joining.
Thank you so
Thank
much.
you, Dr.
Now,
Suvarna, ma'am.
yeah,
you,
now
ma'am.
I invite the immediate past president of AMOGS, my mentor, Dr. Rajendra Singh Pardesi sir, who is always very supportive and guiding us on all the fronts. So all of you know him as immediate past president of AMOGS.
It's okay.
And, yes, sir.
It's
So
okay.
over to you, sir, for your precious words.
Good evening, all.
Now is Antenatal
Respected Chief Guest Dr. C.N. Purandare sir, Dr. Hiremet sir, Guest of Honors Dr. Suvarna Khadilkar ma'am, Dr. Madhuri Patel, and current present President of KSOGA, Dr. Bharti Rajsekar, past President of KSOGA, Dr. Vidya Thobbi, then Dr. Kiran Kurtakoti, our President, and AMOGS and office bearers and KSOGA office bearers, Dr. Nagaraj, Dr. Rajasri Paladi, Dr. Suman, Dr. Asrana. First, I wish to congratulate Dr. Sneha Buyar for organizing this webinar jointly with KSOGA. Topics chosen are of importance in day-to-day practice. And with the galaxy of faculty, chairperson, panelists, I think this is going to be a great webinar. I wish every success to Dr. Sneha Buyar for her future endeavor in FOXI as Vice President FOXI in forthcoming election. Same thing, Dr. Bharti Rajsekar, KSOGA President, is contesting for Chairperson of Perinatology Committee. I wish every success to Dr. Bharti for her future endeavor in FOXI. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you so much,
Rajendra,
sir.
sir. Thank you very much, sir, for your blessings.
Thank you so much. And Saiti, can you see Dr. Madhuri Patel, madam, joined?
Not yet, ma'am.
Yeah, you guided her, no?
Yes, ma'am.
Did you talk to her personally?
Yes, ma'am.
Okay. So I think we will have her blessings once she joins. We can. I would just take this opportunity to thank everybody, all the respected dignitaries, C.N. Purandare sir, Madam Suvarna Khadilkar, Dr. Madhuri Patel. I'm so sorry for the technical glitches. She is not able to join, but she will be joining soon. And of course, my Dr. Rajendra Singh Pardesi sir from AMOGS side, and Dr. Bharti Rajsekar, our dear friend, Dr. Vidya Thobbi, and all of this KSOGA. I can see Dr. Rajashri. Hello. So I thank all of you. Dr. Rekha Rajendra Kumar, our dear friend, the president of Bangalore Society, joining in, and Dr. Rupa Prakash, Dr. Uma Deshmukh from Bidar, president of Bidar, who is the speaker for today's program, and of course the very helping and much very proactive Dr. Sonia Mantapa and Dr. Anita Gaura. I thank all of you, and thank you all the faculties, chairpersons and panelists for accepting the invitation and joining this program. And with this, I hand over the forum to you, Dr. Sonia and Dr. Anita, to continue with the academic session. Thank you so much once again.
Thank you, Dr. Sneha.
We need some words from our President KSOGA, Dr. Bharti Rajsekar.
Yes, I thought
Yes,
initially she welcome. I was talking to Dr.
No. After the program we started, no, she has not addressed.
Yeah. Please go ahead, Dr. Sonia.
Very good evening and namaste. My pranams to Dr. M.G. Hiremet sir, Dr. C.N. Purandare ji, Dr. Rajendra Singh sir, Dr. Kiran Koti, and all my dear friends here. Dr. Vidya Thobbi is there. Dr. Sneha Buyar, we are all friends here, and I wish this webinar a grand success and looking forward to working with AMOGS for doing many more programs for the betterment of women's health. And without wasting much time, I know Dr. Sonia and Dr. Anita, my associates and my young Turks are doing a wonderful job. Let's go ahead with the academic program and have good interactions so that we can improve the perinatal health as well as reduce hypertensive mortality and morbidity among our women. Over to you, Dr. Sonia and Dr. Anita. Namaste.
Thank you so much, ma'am. Your theme will be carried forwarded the next year. And I thank Dr. Sneha Buyar also for creating this platform between AMOGS and KSOGA. My pronouns to all the pioneers of FOXY, AMOGS, and KSOGA, and participants who have logged in this virtual platform. It's my pleasure to welcome all for the scientific session on antenatal interventions to improve perinatal outcome by Dr. Uma Deshmukh. The importance of our topic today cannot be overstated, as it lies in the heart of our mission to ensure the health and well-being of both mother and their babies. So for this, our speaker today will share her insight on evidence-based practice, emerging trends, and successful interventions that have the potential to transform antenatal care in every center. So for this, it's my distinct pleasure to welcome an esteemed professional, Dr. Rupa Prakash and Dr. Rekha Rajendra, as chairpersons for this session. Today's webinar promises to be enlightening with their experiences. Dr. Rekha Rajendra Kumar, a dynamic president of Bangalore OBG Society. We have already been witnessing that as the president, Madam herself has been at the forefront of numerous initiatives aimed at improving maternal and child health. Her visionary leadership and unwavering commitment to excellence have already set a new benchmark in the field. We request you to chair this session, Madam, and provide valuable takeaway messages for all our participants.
Thank you, Dr.
The
Sonia,
next is,
for allowing us to be here. Thank you.
Thank you, Madam. Dr. Rupa Prakash. She's a past president of Mysore OBG Society. We all know her as a dedicated mentor and an educator, having inspired countless students and young professionals through her teaching and guidance. Her commitment to nurturing the next generation of leaders and innovators is truly commendable. Madam, we are honored to have you with us today, and we welcome you, Madam. Over to you.
Thank you, Sonia. Thank you.
Thank you.
Shall we start the session?
Yes, yes.
Madam.
Please go ahead.
So, thank you very much, Dr. Sonia, and all the team members for having me here as the chairperson for a wonderful session. We all have been struggling to reduce perinatal mortality, and definitely by good antenatal care, perinatal mortality has considerably reduced compared to years before. In India, we have lowest perinatal mortality in the state of Kerala, and we know that they are much ahead of times. And because of dedicated service, good antenatal care, and awareness among patients about the need for utilizing the antenatal care, perinatal mortality has come down. So today, I welcome Dr. Uma Deshmukh, the president of Bidar Society. Can we have her CV, please? Yeah. So Dr. Uma Deshmukh, the president of Bidar Society, who will be enlightening us on the antenatal interventions which help us reduce perinatal mortality. So to introduce a wonderful speaker, she is the advisory committee member of PCPNTT Bidar District, nodal officer for maternal mortality, president of Bidar Society 23-24, executive committee member for Women Doctor Wing, instructor for Jiva Raksha, training for medical students, and she has the credit of receiving Best Doctor Award from an NGO from Bengaluru, and Sarvottam Seva Pratishthi from Government of Karnataka, Sri Shakti Pratishthi from Sharanabasava University of Kalburgi, and several others. So let us hear from Dr. Uma about the antenatal interventions which help us reduce perinatal mortality, which is really a burning issue. Not only for the patient, it is a sad thing for the patient to lose a baby after 28 weeks of pregnancy or in the first week of the newborn period. And medico-legally also, we need to be very, very careful to reduce the perinatal mortality. So over to you, Dr. Uma, for your lecture.
Thank you, madam. Good evening, everyone. And my heartful regards to all my seniors, respected seniors. And I'm very happy and for giving me to speak in this webinar. Thank you very much, madam. as a gynecologist, we all are to achieve zero mortality and zero morbidity, right?
Can I interrupt you, madam? Can you please share your screen?
Already sent.
I have sent
to
screen.
I have sent, no?
Yeah,
Anita?
site will be
Yes.
I will be sharing, ma'am.
Yes,
Yeah.
perfect. Go ahead.
Yes.
My topic is antenatal intervention to improve perinatal outcome. And as a gynecologist, always we will do this to achieve zero morbidity and mortality, right? Next.
Madam.
Hello.
Yeah.
As a WHO guideline on antenatal care 2016, first main outline is to development of WHO ANC guideline. It will give recommendation, what's new and what are the implementation, research and monitoring and evaluation. Next slide, please. Anita?
Changed, madam. Next slide,
Yes,
she's in.
it is changed.
No. Previous slide, Anita.
No. Next.
Yeah.
This is the outline.
Yeah.
Go ahead.
Anita?
Next. I think you should have shared with somebody.
Next. ANC is critical through timely and appropriate evidence-based actions related to health promotion, disease prevention, screening, and treatment. We can reduce the complication from pregnancy and childbirth, reduce the stillbirth and perinatal death with the integrated care delivery throughout pregnancy. Next. Previously, there were 4 visits of WHO ANC model involved specific evidence-based intervention for all women carried out at 4 critical times, also known as the focused antenatal care model, that is FANC, and other is part of pregnancy, childbirth, postpartum and neonatal care, PNC. The quality throughout the continuum of care, WHO envisions a world where every pregnant woman and newborn receives quality care throughout the pregnancy, childbirth, and the postnatal period. Prioritize person-centered health and well-being, reducing the mortality and morbidity, providing respectful care that takes into account women's views, optimizing service delivery within health systems. Women want a positive pregnancy experience from ANC. A healthy pregnancy for mother and baby, including preventing or treating risks, illness, and death. Physical and social cultural normality during pregnancy, effective transition to positive labor and birth, positive motherhood, including maternal self-esteem, competency, and autonomy. Medical care, relevant and timely information, emotional support, and advice can prevent the mortality and morbidity. Development of the guidelines. Next slide, please. Next. 2016 ANC guideline, essential core package of ANC that all pregnant women and adolescent girls should receive with the flexibility of employ different option based on the context of different countries. What is the content of the model or package? Who provides the care? Where is the care provided? And how is the care provided to meet the needs of users? Complement existing WHO guidance on complication during pregnancy. What are the evidence-based practices during ANC that improved outcome and led to positive pregnancy experience? how should these practices be delivered? Next slide, please. Work stream for the guideline evidence synthesis, individual interventions, antenatal testings, barriers and the facilitators to assess and the provision of ANC. Health system interventions, large-scale WHO ANC models, that is 4-visit case studies. Next, please. Recommendation on ANC. 49 recommendations were grouped into 5 topics areas, that is nutritional interventions, that those are 14. A. B is maternal and the fetal assessment, 13. And C is preventive measures, and D is interventions for a common physiological symptoms. Those are 6. And E is health system interventions to improve the utilization and quality of ANC. Those are 9, including 10 recommendations relevant to routine ANC from the other WHO guidelines. Next slide, please. Recommendation. Next. First is nutritional intervention. Counseling about the healthy eating and keeping the physically active during the pregnancy is recommended for the pregnant woman. Second one is, in undernourished population, nutrition education on increasing the daily energy and protein intake is recommended to reduce the risk of low birth weight. In an undernourished population, balanced energy and protein dietary supplementation is recommended to reduce the risk of stillbirths. These all are the context-specific recommendation. In an undernourished population, high protein supplementation is not recommended for pregnant women to improve the maternal and perinatal outcome. It is not recommended. Next slide, please.
Dr. Anita, keep moving slides bit faster because it's a lengthy presentation.
Nutritional intervention, that is daily oral iron. That is how we are giving 30 milligram to 60 milligram elemental iron, and 400 microgram of folic acid is recommended. And this is next is the intermittent oral iron and folic acid supplementation with a 120 milligram of elemental iron. And next is daily calcium supplementation. Vitamin A supplementation is only for a pregnant woman in the areas where the vitamin A deficiencies are seen, is in a severe public health problem to prevent the night blindness. Next. Zinc supplementation also is needed, only recommended in a context of rigorous research. Multiple micronutrient supplementation, vitamin B6, vitamin E, C, D, and daily caffeine intake is also lowering the daily caffeine intake during pregnancy. We have to recommend. Next. Next slide, please. Maternal assessment. Now, nutritional is over. Now, the maternal assessment. The full blood count testing is recommended method for the diagnosing anemia in pregnancy in setting where the full blood count testing is not available on a site hemoglobin. Only now we are doing in a periphery also, only hemoglobin we are doing. And routinely midstream urine culture is also recommended method for diagnosing the asymptomatic bacteriuria in pregnancy. It will cause the low birth weight, and this is also recommended with the context specific. And a clinical inquiry about the possibility of intimate partner violence also should be strongly considered at ANC visit. Next. Maternal assessment again in S2. Hyperglycemia first detected at any time during pregnancy should be classified as either gestational diabetes mellitus or a diabetes mellitus in pregnancy according to the WHO criteria, which is recommended. And a healthcare providers should ask all pregnant women about the tobacco use, past or present, exposure to secondhand smoke as early as possible in the pregnancy or every antenatal care visit. Then also alcohol and other substances also. And in a high prevalence settings, even the providers initiated testing and counseling of a PITC, that is for a HIV, should be considered routine component of the package of care for the pregnant woman in all ANC settings. And settings where the tuberculosis prevalence in the general population, that also systemic screening of the active tuberculosis should be considered for the pregnant woman as a part of antenatal care. Next slide, please. And now the fetal assessment. Daily fetal kick counting, such as the count to 10 kick charts, is only recommended in the context of rigorous research. It is a context-specific recommendation. And replacing the abdominal palpation with a symphyso-fundal height measurement for the assessment of the fetal growth is not recommended to improve the perinatal outcome. A change from what is usually practiced abdominal palpation or the symphysis fetal height measurement in a particular setting is not recommended. And routinely antenatal cardiotocography is not recommended for the pregnant woman. And one more, ultrasound scan before 24 weeks. Early ultrasonography is recommended. And for the pregnant woman, to estimate the gestational age in an early scan and improve the detection of the fetal anomaly in the second trimester, multiple pregnancy, reduce the induction of labor for the post-term pregnancy, and improve a woman's pregnancy experience. And routine Doppler is not recommended. Routine Doppler ultrasound examination is not recommended. Next slide, please. Preventive measures. A 7-day antibiotic regime is recommended for all asymptomatic bacteriuria to prevent the persistent bacteriuria, preterm labor, and low birth weight. And antibiotic prophylaxis is only recommended to prevent recurrent urinary tract infection in a pregnant woman in a context rigorous research. And in a context specific recommendation, one more is antenatal prophylaxis with the anti-D immunoglobulins also at 28 weeks and 34 weeks. In endemic areas, preventive antihelminthic treatment is recommended for a woman after the first trimester as a part of worm infestation for a reduction worm infection reduction program. And routinely we are doing in a government hospital in a second trimester and third trimester, one single dose of albendazole we are giving. And we are marking it in a case sheet. And tetanus toxoid vaccination is recommended for all pregnant women depending on the previous tetanus vaccination exposure to prevent a neonatal mortality. But the newer one is TDAP we are giving, TD, but to prevent the in a perinatal diphtheria of the baby, to prevent that, now we are giving TDAP. Next slide. Preventive measures. In a malaria endemic case only, these drugs are recommended. Preventive treatment with sulfadoxine, pyrimethamine are given in a context specific. And oral exposure prophylaxis of tenofovir, that is antiviral for a HIV. It is also context specific recommendation. Next slide, please. Common physiological symptoms. For a nausea, we are recommending ginger, vitamin B6 in an early pregnancy. And advice on a diet and lifestyle is recommended to prevent the relief of heartburn. It will be common in a pregnancy. Antacid preparation can be offered to women with troublesome symptoms. And in a case of leg cramps, vitamin E, even magnesium, calcium are recommended. And for pelvic pain, regular exercise are recommended. Acupuncture, physiotherapy, and support of belts, these are the recommended. And even wheat bran and other fiber supplements for a constipation. And other pharmacological options such as compression stockings, leggings in case of a varicose veins, edema and pregnancy. Next slide, please. And health system interventions to improve the utilization and quality of ANC. It is recommended that each pregnant woman carries her own case notes during pregnancy to improve continuity quality of care and her pregnancy experience. Midwife-led continuity of care models in which non-midwife or a small group of a non-midwife supports a woman throughout antenatal, intrapartum, postnatal continuum are recommended for a pregnant woman in setting with the well-functioning midwifery programs. It is also context-based. And the group antenatal care provided by the qualified health care professionals may be offered as an alternative to individual antenatal care for a pregnant woman in context of rigorous research, depending on a woman's preference and provided that the infrastructure and the resources of a delivery of group antenatal care are available. This also context specific. Next slide, please. Health system intervention to improve the utilization and quality of ANC. That is community mobilization through facilitated participatory learning and action cycle with a women's group is recommended to improve maternal and the newborn health, particularly in rural setting with a low access to health services. Participatory women's group represent an opportunity for women to discuss their needs during pregnancy, including barriers to reaching care and increase the support to pregnant women. And package of intervention that include household and community mobilization and antenatal home visits are recommended to improve. Now the ASHA and ANMs are going and they are giving the services. Next. Health system intervention to improve here the task shifting, the promotion of health related behaviors for maternal and the newborn health. Including the lay health workers, auxiliary nurses, midwives, and the doctors are recommended. And task shifting of the distribution of recommended nutritional supplements and the intermittent preventing treatment in a pregnancy for malaria prevention to broad range of cadre, including auxiliary nurses, midwives, doctors are recommended. And policymakers should consider educational, regulatory, financial, and the personal, professional support intervention to recruit and retain qualified health workers in rural and remote areas. And health system, that is fourth one, to improve the utilization of the quality ANC, that is antenatal care models with a minimum of 8 contacts are recommended to reduce the perinatal mortality and improve the woman's experience of care. Earlier it was 4, now new one is 8 contacts are recommended. This is what's new, that is 8 contacts. Antenatal care models with a minimum of 8 contacts are recommended to reduce the perinatal mortality and improve the woman's experience of care. This GDG recommendation was formed by evidence suggested increased perinatal deaths in a 4-visit of ANC model and evidence supporting improved the safety during the pregnancy through increased frequency of maternal and fetal assessment to detect complication and evidence supporting improved health system communication and support around pregnancy for a woman and families. Evidence indicating that more contact between the pregnant woman and the respectful, knowledgeable healthcare workers is more likely to lead to positive pregnancy experience. There are no important difference in a maternal and perinatal health outcome between a ANC models of the included at least 8 and the ANC model that included 11 and 15. 4 to 8 will be best. See here, WHO FANC model, that is first visit 8 to 12 weeks in the first trimester, second trimester, third trimester, 4 visits. In third trimester, 2 visits were there. It is now 8 contacts are first contact up to 12 weeks, second context 20, and third is 26, fourth 30, 34, 36, 38, and 40.
Uma madam, sorry to interrupt you. Another 2 minutes remaining.
Yes. Early ultrasound is recommended for estimation of gestational age, detection of the fetal anomaly, multiple pregnancy, enhance the maternal pregnancy experience, and ultrasound scan after 24 weeks. That is, late ultrasound is not recommended if she has undergone first trimester, first early ultrasound. And ultrasound equipment can also used for the other indication also. Next slide. Effective implementation of ANC requires health system approach, strengthening the continuity of care, integrated service delivery, improved communication with the support for women, availability of supplies and commodities, and empowered healthcare providers. Implementation and dissemination. Here, implementation of adoption and implementation of the ANC model. Essential core package of ANC that all pregnant women and adolescents should receive, with the flexibility of employ different option based on the context and needs of different countries. What is the content of the model? Who provides the care? Where is the care provided? And how is the care provided to meet the need of users? Next, implementation, research of and monitoring and evaluation. Implementation and monitoring and evaluation and learning will be crucial. Development of indicators and priority research questionnaires. Next, dissemination. There will be policy briefs, ANC model, early USG, and interactive websites, tool for the implementation, regional dissemination workshops, and translation of the guidelines and webinars can help to improve this. Guidelines contributors are all these WHOs, all members of DGD, WHO. These all are doing this work. Next slide. To achieve the every woman, every child vision and the global strategy for a woman's children's, adolescents' health, we need innovative, evidence-based approach to antenatal care. I welcome these guidelines, which aim to put women at the center of care, enhance their experience of pregnancy, and ensure that babies have the best possible start in life. Thank you, one and all. Thank you for your attention.
Thank you so much, madam. Finishing so much on time. On behalf of Dr. Rupa Prakash and myself, Rekha Rajendra Kumar, congratulate you for such an elaborate talk on a very difficult topic. You touched everything. You have also explained to us on the tobacco, alcohol also, which is not so rare in the present day women. It does not appear something totally out of the topic when we talk to them and ask them the questions. You spoke about the entire ANC model, the implementation, the dissemination of knowledge, the research modalities, how we should take it forward, the knowledge guidelines, everything. Thank you so much.
Thank you.
For
Thank you,
such
madam.
a lucid presentation.
Thank
Dr.
you
Rupa,
and given me
thank
this
you.
opportunity. Thank you very much.
Dr. Uma, for a wonderful deliberation of this talk. And
Thank
WHO
you,
has
ma'am.
extensively dealt, and it's very difficult to remember the terminologies which WHO says. But in our practice, your 8-visit antenatal care was a good one. It really touched me because 4, I always used to feel that it is not enough to detect problems. They have now revised, so it is very good that we have 8 visits. But of course, this is all applicable to a rural underdeveloped population, I feel. But in urban area, we do not have much difficulty. In fact, they ask for an antenatal visit. There is no need to, postpone. So thank you very much for your wonderful lecture.
Thank you, madam.
Now I think, thank you. I think queries we can answer.
Any other comment from the other chairperson, Rekha?
No, there are no queries in the chat box.
Yeah.
And if at all, they can put it in the chat box so that Uma madam can handle
we will always have.
Yeah. I would just make a comment, Dr. Uma. That was a wonderful presentation. And of course, what I wanted to talk about this topic is, people are not aware that there are such, WHO antenatal care guide. I'm the one who is, repeatedly asking even Dr. Muralidhar Pai to talk about the WHO labor care guide, that is intrapartum care guide. But I just thought this is very, very vital, as far as prevention of the complications are concerned, because you can really predict it at the earliest. What this WHO has come up with, saying that, 4 visits and then 8 visits, and it has also quoted that there are studies with almost 12 to 15 visits, but they have not been proven superior as far as the outcome is concerned. So it
is enough.
Efficacy, yes.
Yeah.
So that is what is important. And of course, there is one more presentation from my side where I simplify this WHO antenatal care guide as, screening for common disorders during pregnancy. It can be of practical help to the routine practicing obstetrician. So thank you so much, Dr. Uma.
Thank you, madam.
Sonia?
Yes, madam. I think there was difficulty in actually texting questions in the chat box, but then we will move ahead with the panel discussion and can take the questions at the end. I'm sure our chairpersons and also Dr. Uma would be there till the end of this session, and we'll take up the questions after that.
Sonia, probably as the president of KSOGA, all questions are going to Dr. Bharti.
No, I think there was a difficulty.
That's what happened to me. Right. Thank you.
Thank you, ma'am. The permission of the delegate faculty, I think we'll move on to the panel discussion. Okay, the panel discussion for today's Yes, ma'am?
Yeah, please move on to this panel.
Thank you, ma'am. Today's panel discussion is hypertensive disorders in pregnancy, which will be moderated by Dr. Sneha Bhoyer, ma'am. So Dr. Sneha Bhoyer, ma'am, she is, madam is candidate for Vice President for Foxy Western this year. We wish you all the best, and on behalf of everyone here, so International MS Signature Award for Phenomenal Leadership in 2020, Asia GCC Award 2021, Dr. S.N. Malhotra Individual National Award for Outstanding Work in Rural Obstetrics 2008, Dr. Duru Shah Distinguished Community Service National Individual Award 2022, Individual Award Champion of Foxy Award for 2 consecutive years, 2020 and 2021, and Hira Award for 22, Dr. Anandibai Joshi, State Award by Government of Maharashtra, Lokmat Healthcare Excellence Award 2020. Ma'am has more than 300 talks, 10 plus keynotes and orations, and moderated many sessions. So, sorry for the disturbance. Lokmat Healthcare Excellence Award 2020 and 300 plus talks, 10 keynotes and orations, and moderated 100 plus sessions. Ma'am is Foxy Breast Committee Chairperson 1921, GCM ICOG 2020. 1 second.
I think that should be enough, Dr. Anita. We can go ahead with Dr. Sonia, I think you can introduce.
Yes, madam. Actually, 100 plus moderation will add on one more moderation to the HTP talk, which is most.
You can skip that. Thank you so much. So go ahead. Introducing Dr. Vidya.
Yes, Anita.
Yes, ma'am. Sorry.
I think Anita's bandwidth is low.
Yeah, I think she's got some network issues.
Yeah.
Department OBG Alamin Medical College, Vijaypura. President KSOGA 2023 State Advisory PCPNDT Board Karnataka, Chairperson Food Drugs and Medical Surgical Equipment Committee Foxy 2018-2020, Best Committee Foxy Award Dr. Mehrudara Hansotia 2020, ICOG Governing Council Member 23 to 25, Foxy Champion Award 2019, National Corresponding Editor JOGI, Organizing Chairperson KSOGA 2016, President Bijapur OBGYN Society 2019, Secretary Bijapur OBGYN Society 2017, publications in various books and contribution to Foxy Focus, speaker at national and international conferences, papers at national and international conferences, organized various CME workshops and awareness programs, advisory faculty of Board of Rajiv Gandhi University of Health Sciences, postgraduate and undergraduate teacher for 30 years. Over to you, Dr. Sneha ma'am.
Yeah. So Dr. Anita has been already introduced. I would just introduce and welcome. I think Dr. Anita is from Kalaburgi, and thank you, Dr. Anita, for coordinating this session wonderfully, and we welcome you as panelists. Dr. Soumya Patil, who is from Kalaburgi again, and she is presently working as assistant professor in the Department of Obstetrics. We welcome you, Dr. Soumya. Dr. Nivedita Bhavi, who is serving in the District Hospital of Bagalkot, and of course with the work experience of 13 years and field of interest of high-risk obstetrics. Very good. We welcome you, Dr. Nivedita. And we have Dr. Vidyashree GM, who is currently working as assistant professor at SN Medical College, HSK Hospital, Bagalkot, and her areas of interest are also high-risk obstetrics. So I'm happy to have you, Dr. Vidyashree. Dr. Rameshwari Malsetti, welcome, Dr. Rameshwari Malsetti, who is the assistant professor in the Bidar Institute of Medical Sciences. Next, yeah, Dr. Hemlata, who is again assistant professor in the Department of Mysore Medical College, Mysore, and of course her special interest in the emergency obstetrics. So do we have one more panelist? Yeah, so I welcome all of you, and without much ado, I think we go ahead with the panel discussion. I would like to share the screen, and I just hope you all can see my screen as full screen also. Okay.
Yes,
so a very good evening to all of you, and as chairperson for this emergency obstetrics committee, I have been moderating various panels, but what we have observed over 32 years of my high risk obstetric practice, that hypertension, hemorrhage, and sepsis, these are the three major killers of our women. And we do have various predictive factors. We do have certain, predisposing factors, and we do know that there are certain aggravating factors which actually, if you prevent them, then we can prevent the illness, or at least we can reduce complications to that. Likewise, we do have, the predictive factors for hypertensive disorders of pregnancy, including the maternal characteristics, her age, BMI, history of diabetes mellitus, hypertension, and even hypothyroidism. We do have a scoring system, what we label it as SDP Justosi score. And in spite of everything, we are having the biophysical and biochemical markers as well. Still, the incidence of maternal mortality because of hypertensive disorder has not been reduced over the years. We do have the predictive factors, and you do have the preventive measures like low dose aspirin and high dose calcium. In spite of this, the morbidity and the mortality associated is not reduced. This is the basic pathogenesis of hypertensive disorders. So Professor Mohammad Fatala, who is the past president of WIGO, has expressed, that women are dying not because of the diseases we cannot treat, but because the societies have yet to make the decision that their lives are worth saving. It's really a very, the matter of introspection that we really have to think about this, that in spite of having all these facilities, why we are not able to utilize them and prevent the morbidity as well as mortality. So without much ado, I go to Dr. Anita Gaura. And we start with, I do have certain case scenarios, but I will take you through one single case where you have this young primary gravida belonging to low socioeconomic status with no known medical illness and no significant family history. She's antenatally booked, she's coming to you regularly, and she has got a uneventful course up to, say, maybe around second and third trimester. At 32 weeks of gestation, she is reported at OPD with a blood pressure of 140/90 millimeter of mercury. So how should you go ahead with the management of this patient, Dr. Anita Gaura? My question to you, whether you will label her as hypertensive right now, if at all yes, then when, and how do you go ahead with the management? Dr. Anita.
First, I did like to establish her diagnosis. She's at 32 weeks with one reading of blood pressure, which is 140/90 millimeters of mercury.
Yes.
So I want to repeat this blood pressure first thing, so that we get at least, if we want to label her as hypertensive disease, so at least two readings, which should be 6 hours apart, greater than or equal to 140/90 millimeters of mercury.
Okay.
So one is the establishing the diagnosis.
Okay.
Apart from that, we will go ahead with to assess the proteinuria which she has. So because she's come to our OPD, so ideally it is 24-hour protein or protein creat ratio, or routinely which we are doing is the dipstick method.
Okay.
So a dipstick test will also help us.
Yeah. But my question to you
is
very simple, that whether you will label her as hypertensive. What is your answer to this?
With one reading, we have to have another reading for higher blood pressure recording.
Yes, another recording maybe 4 to 6 hours later. Okay. Suppose it is 140/90 again. Then what will you do?
So yes, she will be hypertensive. So you do a baseline investigation, and we can start her on antihypertensives.
Okay. Now how do you classify her and how do you manage her? How do you manage her? From this point, she's got 140/90 and you have done her baseline investigation. First and foremost, what investigations you would like to do for her at this time? First time when she is diagnosed as hypertensive.
One is the proteinuria, if she is fitting in the this diagnosis of preeclampsia. Then we go for routine CBC also we need, because we need to know the platelet counts.
Yes.
Then liver function test and renal function test.
Okay.
Apart from that, USG for Doppler studies and the well-being of the fetus.
Okay.
And
okay, that is about investigation. Will you ask this patient certain symptoms, whether she has it? Because you have labeled her as hypertensive. You want to categorize her? Whether you would like to ask her for certain symptoms, whether she has some
if she has any
okay,
anybody else? These, if they have, firstly they may complain of pedal edema, which is the most common thing which we are seeing with which we see with hypertensive patients.
Okay. Anybody else want to add anything to this?
Any epigastric pain, headache, nausea, blurring of vision.
Suppose she has, then what will you do? Dr. Vidyashree, Dr. Nivedita, please unmute.
She has headache, nausea.
Yeah, Dr. Vidyashree, please go ahead.
So, in the case of the patient complains of imminent signs, if there are complaints of imminent signs, so in that case, we may have to start. I mean, she will be considered as severe preeclampsia.
My question to you is, her blood pressure is 140/90. Whether you would like to take this pregnancy ahead or you would like to terminate, and how do you?
I would first of all, I need to categorize whether it is a non-severe preeclampsia or whether it is severe preeclampsia.
Yes, perfect.
So in case if it is a non-severe preeclampsia, then definitely with antihypertensives I can continue the pregnancy. And if at all, she falls into the category of severe preeclampsia, then depending on the gestational age and depending on the other signs and symptoms and other depending on the investigation findings, I would like to see whether I can continue the pregnancy at least until the lung maturity of the fetus could be attained, or whether it requires, if other signs are such that the patient could lead to it could lead to severe morbidity. In that case, probably I'll have to take a decision to terminate the pregnancy.
Okay.
So
Yeah, so correct. So previously, we had this once upon a time, if you remember, this was 3 decades, and before that, delivery was the only cure for the whole spectrum of hypertensive disorders of pregnancy, right? Once she develops hypertension, we have to terminate the pregnancy. That was a dictum maybe more than 3 decades ago. But now we have this, we have to consider the gestational age at which it is diagnosed, the severity of the disease, and the rate of progression. Also, we have to consider the maternal and fetal conditions, right? That these are the parameters which you decide for the management. So suppose this patient has 140/90 blood pressure, but if she has alarming symptoms and signs, we have to consider this as severe hypertension in spite of 140/90. Do you agree to this?
Yes, absolutely.
Yes, because nowadays, previously these are the investigations. I would ask Dr. Nivedita to comment on these investigations. Why do you want, what all investigations, and why do you want to do these investigations? What is the information you get from these investigations?
Ma'am, these investigations will basically suggest us the end organ
all of you
damage.
to put on your video, please, because I'm not able to see you all. Yeah, that is good. Yes.
Ma'am, all these symptoms and signs are suggestive of end organ damage. That's why we are supposed to check in for all these investigations and ask for the symptoms and look out for the signs. So, but depending upon the condition, if it is severe, if she gets fits into a severe preeclampsia, then we have to manage her well, taking into the fetal condition, and then if need of termination arises, you can terminate the pregnancy when the fetus is mature enough.
Okay, so this patient is 32 weeks and she's got 140/90, right? You do the this obstetrician was from previous generation. She just thought 140/90, it's a mild hypertension, so she just sent her home. Okay, so now now you are wise enough, you have done all these investigation. So I'm just asking you, what all information do you get from all this investigation? From complete blood count, what is the information you are getting?
Yes. So from complete hemogram, yes. So I will get information about the hemoglobin. Another important information I would also get about by looking at the RBC indices, if there is any microcytic anemia or macrocytic anemia. I can look at the platelet count.
What about hematocrit? Is it
hematocrit? Yes, hematocrit will be raised in case if there is hemoconstration, which will happen because of preeclampsia.
Yes.
So the hemoglobin, hematocrit, the platelets. So all of them can give an information about what is happening in the.
One more thing. Yes, peripheral smear.
Peripheral smear also would be very important.
Hemolysis.
Where the signs of hemolysis also could be recognized.
Yeah.
So by complete urine examination, we will come to know if there is albuminuria, where protein will be present, and if there is any urinary tract infection, that also can be identified. And by liver enzymes, yes, in case of the liver, if there is a liver injury, which mainly happens if there is a HELP syndrome. So SGOT and SGPT.
It's not only HELP syndrome, but before that, the liver enzymes are elevated. They can be, isolated. Okay. So what is the normal level of liver enzymes during pregnancy? They are also elevated a bit. So how do you diagnose that whether they are abnormal or abnormally elevated?
If the increase is more than 2 times.
Yes, that is
2 times the normal. Then we consider that it is increased and it is abnormal.
Yes.
And bilirubin levels will be increased if there is a hemolysis. And LDH will be again increased whenever there is a hemolysis.
Okay.
Renal function test. Renal function test, again, creat will, if it is more than the upper limit of the normal, then that will indicate that there is a renal injury. So that also indicates that the hypertension is severe. And platelet count, as discussed, if it is less than 1 lakh, so it is thrombocytopenia. So again, we'll have to consider other differential diagnosis for thrombocytopenia. And serum electrolytes, there could be derangement of serum electrolytes. And so in peripheral, and peripheral smear hemolysis can be seen, and fundoscopy, there could be different levels of vascular changes that can be seen through in fundoscopy.
Okay, so proteinuria, this theoretical aspect, we are not going to go. We have already talked about all this. Whether for this patient, Dr. Rameshwari, do we have Dr. Rameshwari? Yes, Dr. Rameshwari? No? Okay. So anybody can take up this right from Dr. Anita now. Once again, the cycle continues. When to start antihypertensives? Dr. Anita.
Once we have established the diagnosis, I think, yes, once we have established the diagnosis and she is hypertensive, we have to start
No, I'm not getting your voice. Can somebody talk about this, Dr. Bhavi? Yes.
Yeah, ma'am. Once the establishment of diagnosis of hypertension, you can start her on antihypertensives. We have a wide range of hypertensives.
No, but then what is the level? That is what I'm asking you. When do you start antihypertensives? What is the cutoff?
Anything more than 140/90, if she has the...
So our patient has 140/90. Will you start her on antihypertensives?
Yeah, ma'am. We
Yes.
will...
And what are your options for antihypertensives for this patient, 140/90?
Yeah, ma'am. Nowadays, we are starting them on labetalol, 100
What are
mg.
your options? Then we will ask you how to justify which one.
Yeah, ma'am. Labetalol, calcium channel blockers like nifedipine, because it's 140/90, and we assume there are no severe symptoms. We can start her on oral therapy of labetalol and calcium channel blocker like nifedipine, ma'am.
Okay, so which formulation of nifedipine you want to use? Because which formulation of nifedipine you want to use?
Oral nifedipine, ma'am, not sublingual.
Yes, but then oral formulation also you have two different types, the capsule as well as the sustained release, Nicardia retard, right? Because for this is a non-severe hypertension suppose. Tablet Nicardia retard or nifedipine retard, 10 milligram. Okay. So you have three choices. You have alpha-methyl-dopa, nifedipine retard, and of course tablet labetalol. Now, for this patient, how will you decide which is the best and how do you justify? Now, why not alpha-dopa? You tell me first. Why not alpha-dopa? So before that, I will just give you the evidence that according to NICE NHS 2010, actually blood pressure above 150 by 100, that is 150 systolic and 100 millimeter of mercury diastolic. That was a cutoff for starting the antihypertensives. But now, according to FOXI, ICOG, and World Gestasis Organization, they recommend that antihypertensives should be started at 140/90. Okay. And of course, because we are discussing the non-severe hypertension first, we have three choices: the tablet alpha-methyl-dopa, Nicardia retard, and the labetalol. So how do you how do you decide which one is the best?
Madam, can I answer?
Yes, definitely. It's open for...
there has been a recent guideline by WHO in 2020 wherein they have recommended that we have to start antihypertensives even for non-severe preeclampsia. And according to the various studies that they have analyzed, so they recommend that beta blocker is a best antihypertensive to be started.
Yeah. But my question, we have already said we have three options: alpha-methyl-dopa, Nicardia retard, and labetalol. So my question to you is, how would you decide why not alpha-methyl-dopa? That is what I'm asking.
So according to that study, they say methyl-dopa, which only reduces severe hypertension, whereas beta blocker.
No, I don't agree with you that methyl-dopa reduces severe hypertension.
is also coming with a set of adverse reactions.
Yes, perfect.
It is hepatotoxic, it is
What are those? What are
pancreatitis,
those?
myocarditis, it is hepatotoxic, it is causing pancreatitis, it is causing depression. And apart from nausea, vomiting, there are rashes. So it is also coming with a wide range of side effects. So that is why alpha methyl-dopa, which was earlier the first line, now it has come down.
Yes,
So that
down and it is
non-selective
not
alpha beta
available.
blocker like labetalol has taken the first.
Yeah. So first and foremost, alpha methyl dopa is not commonly available now.
It's commonly
Dr.
caused
Nivedita.
hypertension.
Dr. Nivedita, yes.
Alpha methyl dopa is causing more of postural hypotension, ma'am. And chronic use of it is evidence-based medicine tells you that chronic use of it will sometimes cause you rebound hypertension also because of the saturation of the receptors. That's why alpha methyl dopa is being sidelined by the other two drugs, ma'am.
Yes. So do we have Dr. Anita here? Yeah. Anita, are
Yes,
you
ma'am.
able to hear us?
Yes, ma'am.
Yeah. So if I share, see, our generation is the one who has, do we have Dr. Vidya Thobi? Alpha methyl dopa we have used, right and left. So we used to start the antihypertensive. If you have a patient who is hypertensive, you start, 1 TDS, 1 QID. That is how we used to start. Maybe sometimes even 2 TDS and 2 QID, and for 24 hours there is no effect. Okay, and suddenly when it starts, so the onset of action, the time taken for onset of action is almost 24 hours and more. And once it starts, acting, then definitely there was a profound hypotension. So even if the patient gets up from bed and starts walking, she will fall down. Okay, so the postural hypotension, and of course the very profound hypertension, that was a side effect. And then of course depression, mental disturbance, even sedation. Sometimes the patient used to get so severe headaches that you are not able to differentiate it whether it is imminent eclampsia or whether it is because of alpha methyl dopa. And then of course certain hematological problems also, in the thrombocytopenia, hemolysis, and of course
Hemolytic anemia and reversible leukopenia it has caused.
So false positive Coombs test also, ICT used to come just as false positive. So that is how it was, So nowadays it is not available. That is also one more reason for not use. Okay, now tell me, why not this Nicardia or nifedipine? So how now you remain with two things only, nifedipine and labetalol, or so how do you decide? Both of them, they are mild, tablet nicardia and tablet labetalol. So you are having a very mild antihypertensive. Then how do you decide between the two for this patient?
Ma'am, even this nifedipine is causing a lot of headache and postural
Tachycardia,
What else?
Sinus tachycardia, headache.
Yes.
Tachycardia.
So if you have a patient who is having severe tachycardia, you will not use nifedipine, you will use labetalol.
And it's
correct. And vice versa. If you have a patient with severe brady, heart blocks, CCF, then you will not use labetalol, use nifedipine. And one more, if you have a patient with asthma, okay, congenital heart blocks and CCF, then you will not be able to use the labetalol, but you have to go for nifedipine. So that is how, in short, practically, why? Because labetalol is cardioprotective. Basically, it works by two effects. Why to prefer labetalol? Now, if somebody can talk about this.
Madam,
yes. Anybody, please go ahead.
Labetalol, it is
hypertension at a.
Hello.
Anybody, just say who is speaking. Please let me know.
It is labetalol is a selective alpha 1 and beta blocker. It reduces the peripheral vascular resistance and it reduces the blood pressure. It has a very minimal side effects as compared to any other, and it has much effect on the cardiac output.
Yes.
This is basically its mechanism, how it acts. Because of its alpha 1, that beta blocker effect only, we are not preferring to give in asthmatic patients.
Okay. Okay, that is one. That it, but then what is the advantage over other antihypertensives?
Ma'am,
It gradually brings down the blood pressure. There is no sudden fall in blood pressure.
Sudden
And
fall
then
in the blood
once
pressure.
it is maintained, it maintains its.
It will maintain for a long time.
Yes, definitely. And also, it does not interfere with the uteroplacental circulation, the fetoplacental circulation. Okay, correct. So it does not interfere with the growth of the baby. Correct? So, Dr.
Yeah.
Sonia, may I ask what is the role of bed rest and salt restriction in these patients? Do we have Dr. Soumya? I think Soumya and who else is not there?
Rameshwari is not there.
Can you please rename? I can see somebody as doctor. Can you please unmute yourself? Yes.
I'm Dr. Hemlata.
Hello, Dr. Hemlata. Can you please talk about this? Role of bed rest, strict bed rest and salt restriction.
There is no much benefit from salt restriction and strict bed rest. And it is salt restriction is only done when they are taking excesses of salt. Otherwise, the normal whatever they take routinely, that is not prohibited, and that has got benefit actually.
So, in fact, if you strictly do salt restriction also, that will be a problem because this patient usually they have hyponatremia, right? So you shouldn't do sodium restriction also. You just allow them to have optimum sodium intake also. Okay. So that is one. And secondly, as all of you know that even strict bed rest is more detrimental than its benefits. It is detrimental. So friends, challenges are what makes life interesting, and overcoming this, what makes it, meaningful. That is how it has been expressed. So I just told you that, this patient, this obstetrician was from a previous generation and she just thought 140/90. She said it is not much. You just keep a watch. If at all you find any symptoms of alarming symptoms, then you come back to me. Okay. So Dr. Nivedita Bhavi, we have this question for you that, after 5 days, suddenly she's brought by the relatives here with severe headache, nausea, upper abdominal pain. When you examined her, the blood pressure is 170/110 and the reflexes are brisk. There is epigastric tenderness also. Now, how do you manage this patient and how do you decide her management further?
Ma'am, because BP is 170/110 and there is epigastric tenderness and deep tendon reflexes are brisk, I consider this as a severe hypertension, and I start her on antihypertensive, ma'am. You can start her.
Yeah, okay. Yeah, go ahead. So what antihypertensives?
Here we can start her on IV labetalol, ma'am. IV labetalol.
What options do you have? What options do you have, and how do you decide? Once again, we discuss that.
Okay, ma'am. We can start her on either IV labetalol or oral nifedipine or IV hydralazine. Initially, they used to use the sodium nitroprusside, but nowadays we are not using sodium nitroprusside. So among all these, because of the good effects of labetalol and cardioprotective actions, we are choosing on to IV labetalol. Initially, we give it in a dose of 20 mg IV over 10 minutes, ma'am. Then
we will discuss the schedule in details a little later. I would just ask you that now that your patient has got, very severe hypertension, she is now in hypertensive crisis. Okay. So first and foremost, you want to reduce her blood pressure, bring her blood pressure down. Okay. Why do you want to bring her blood pressure down at the earliest?
Because one is
one
is to prevent the preeclampsia, ma'am. To prevent the effects of hypertension which are causing the end organ damage.
Okay.
Basically, I want to prevent the end organ damage by reducing the blood pressure, ma'am.
So what are the end organ damage? What it results to? Can we have the list from you?
Yeah, ma'am. It is
convulsions. Yes.
Convulsions causing encephalopathy in the cerebral this thing encephalopathy, ma'am. Then
one is convulsion, eclampsia. Second.
Okay, ma'am. Eye complications like papilla edema, intense grade 4 severe retinopathy.
Okay,
retinal
2. But the very common 71
yeah.
time, what do you expect?
Liver and kidneys, ma'am. Liver and kidneys, basically.
Renal failure.
Very
Renal
severe.
failure.
Yeah, pulmonary edema.
Pulmonary edema, yeah.
Okay. So you have eclampsia, pulmonary edema. Then of course you have acute hepatic rupture, hepatic failure, acute renal failure, and then you can have even myocardial infarction. You can have intracranial complications, right? Intracranial bleeding. Because because such a severe blood pressure, the vasculature is not adapted to it. Correct. And that's the very reason you have to bring it down to at least to a safe level. Maybe 160, 100, 150, 100. Okay. Now you tell me, your first aim is to reduce the blood pressure. So after this, how do you decide whether you can take this pregnancy ahead?
Yeah, ma'am. You can monitor the BP. If the BP gets
first and foremost, you need to send the laboratory investigation. Why? Because you have to differentiate between urgency and emergency. Okay. Because you have to differentiate whether she has had end organ damage already, so that you cannot take this pregnancy ahead, or it is just a severe hypertension, a transient hypertension at this point, and you can control it and take this pregnancy ahead. Correct? So you send the laboratory investigations and look for the end organ damage. You want to control the blood pressure because these are the complications, right? So, Dr. Videshri, we were discussing about what are all the drugs available. So she has already said that you have this intravenous labetalol, oral nifedipine, and then intravenous hydralazine, sodium nitroprusside, and of course NTG infusion, right?
Yes, ma'am.
Very safe. Most of the ICUs they prefer nitroglycerin infusion, NTG infusion, right? So, what will be your policy to reduce the blood pressure? Do you want to reduce it drastically or how?
I wouldn't want to reduce it drastically, madam. But as discussed earlier, so we will be initially starting the at least by about 10% or 15% of blood pressure should be reduced. So in case if the blood pressure was 170, 110 at point of admission, so at least we should bring it about to 150, 100 at one point of time, and then later on we can reduce it further. So at this point of time, our aim would be to reduce the blood pressure to the level where
25% of the mean arterial pressure. That is what they calculated. But as you said, practically 150, 100. That is a safe level, correct?
Yes, ma'am.
Okay.
Yes,
now we come to the various regimes of these drugs. So what somebody can talk about labetalol.
So labetalol can be either given. Maybe other speakers can take it up.
Yes, you can pass it on to the next panelist. Who wants to take up this? Yes.
Labetalol can be given in the dosage of 10 to 20 milligram IV, then slowly, and then after about 20 minutes or so, you repeat and you check the blood pressure. If it's still high, then you increase the dosage. You increase it up to 20 to 80 milligram. Now 40 to 80 milligram you can increase.
Yes. So first 20, if there is no desired response within 10 minutes, then you double the dose, that is 40 milligram. Wait for another 10 minutes. If there is no desired effect, then you repeat again by double. So that is 80. And 80. Even if with 80 there is no desired effect, you can still more repeat 80 because the maximum dosage is only 300 milligram. If at all at this point of time you're not getting the response, the further dosage will not have the response, and you have to add another antihypertensive, right? And these are the contraindication we have already talked about: CCF, asthma, diabetes, and bradycardia if it is very severe bradycardia. Okay. Somebody to discuss on the nifedipine and hydralazine dosage. Dr. Bhavi, Nita Bhavi, Nivedita Bhavi, sorry. Nivedita? Dr. Nivedita? No? Do we have Dr. Nivedita? Dr. Videshri, you can take up.
So Mifepristone for acute control, we will be using capsule mifepristone in the capsule form of mifepristone. For if at all, if you are using for the as a in the long term, in the sense if you are continuing the pregnancy, in that case, we can use retard form of calcium channel blocker. So here,
here we have this severe hypertension, no?
severe
So
hypertension. Yes, ma'am. So
Okay.
at this point of time, we usually use 10 milligrams per oral. We are not going to give any sublingual depin, as it can cause severe hypertension. We are going to use per oral 10 mg nifedipine, and we are going to recheck the blood pressure again after 30 minutes. So if at all, if the BP is still high, we can maybe increase the give a dose of another 10 or 20.
Yes.
20 mg. But after that, if it is still high, maybe we'll have to add on another antihypertensive to control the blood pressure.
Right. So I think we have Dr. Hemlata also, no? Do we have Dr. Hemlata?
Yeah, I'm there, ma'am.
Yes, yes. So for hydrolyzing, can you please describe?
Yeah, ma'am, we can initially start with 5 milligram IV slowly, and then we can repeat this dosage. We'll check the blood pressure. If it is not decreased to the desired level, then we can increase the dose up to 5 milligram IV. This we increase at every 30 minutes or so, and the maximum dosage we can give is around 20 milligram IV, ma'am.
Right. So maximum up to 30 you can give, but then it can increase the risk of, it is associated with sudden hypotension. That is the disadvantage of this drug. Right. So we have already discussed about these drugs. Only warning, this is a very special warning. You have to, never ever sublingual. We have seen patients actually getting collapse, and we have seen patients lost because of this sublingual taping. That dangerous this drug is. So never ever think of giving because we have already discussed, we don't want the blood pressure to come down so drastically. In fact, that will do more harm to the mother as well as to the baby. So the bringing down the blood pressure is a gradual process. Never ever you try this sublingual. And of course, you have these other antihypertensives. If anybody knows, can speak. Otherwise, I can discuss for you. Nicardipine is a similar kind of second generation dihydropyridine derivative. It is also a calcium channel blocker with high vascular sensitivity, and it has, it is a vasodilator, 100 times more potent and more soluble than nifedipine. Therefore, it can be administered intravenously also. This has been used by the ICU units and the intensivist and physicians. We have no experience for this. And also we have this osmolol, which is also ultra short acting cardio-selective beta-adrenergic blocking agent. And this agent is available for intravenous use as well as bolus or infusion. Although esmolol may be useful for therapeutic agent in obstetrics and obstetric anesthesia, concerns about its safety, especially in the fetal bradycardia. That is the reason where people are not using this drug. Now, you have, suppose this patient has had this episode of severe hypertension, you investigated her, she did not have end organ damage, so you controlled her severe hypertension by the intravenous labetalol, and now you are maintaining her on oral labetalol, okay? So you want to reach the level of salvageability for this fetus, and you want to reach 34 weeks, okay? So everything is stable. But then we don't have Dr. Rameshwari even still, right? So Dr. Anita, you can take this question, that what are the other clinical findings and investigations that would warrant termination of pregnancy prior to 34 weeks? Okay. I think, yes.
Okay, ma'am.
Yes. Anybody can.
Prior to 34 weeks of gestation, when it is severe uncontrolled hypertension and she is going in for end organ damage, and there is growth restriction, there are Doppler changes, eclampsia.
Correct.
These are the indications where we want to terminate the pregnancy.
So you have maternal parameters, right? You have maternal parameters like, she's either developing convulsions, going into eclampsia or abruptioplacentity, she's going into HELP or ARF. So maternal condition is at risk, and that is why you may have to terminate. Otherwise, when you have very severe fetal growth restriction, maybe the absent or reversal of end diastolic flow, okay, these are the parameters which can compare you to go for delivery of this baby. So what is the role of prophylactic magnesium sulfate, Dr. Hemlata?
Yes, madam. Prophylactic magnesium sulfate, as per this MACPE trial, which everybody knows, which is a collaborative group. In 2002, they had done a study involving more than 10,000 women with severe preeclampsia from almost 33 countries. They found that they concluded in the trial that 58% reduction of risk of eclampsia is there when compared to a placebo. So now WHO does recommend that you have to start a prophylactic magnesium sulfate.
Yes. So first and foremost, I would just clarify from your side that prophylactic means to prevent the convulsions, to prevent eclampsia. Now we come to what is the regime? What is the dosage schedule for prophylactic magnesium sulfate, and which regime do you prefer? Dr.
WHO recommendation, it's the Pritchard regimen, and I would also prefer to use Pritchard regimen. And in Pritchard regimen, we are giving loading dose and then maintenance dose. The loading dose involves giving 14 grams of magnesium sulfate. In that, 4 grams of magnesium sulfate at a dilution of 20% dilution, we will give IV over 20 minutes, ma'am. And we have to tell the women that she might experience hot flashes, and the remaining 10 grams we will give in the dilution of 50%, and that is 5 grams intramuscularly, deep intramuscularly on both the buttocks. And here, because we are giving deep intramuscular, it can cause pain, so we have to add 1 ml of
So tell me, how do you give the loading dose? You said
loading dose 14
grams. So how many ampules?
4 grams. The 1 ampule contains 1 gram. So 4 grams is 4 ampules. And
yes,
it will be
perfect. That you dilute in how much of normal saline?
12 ml of normal saline.
Because 4 ampules is 8 ml, correct?
Correct, ma'am.
Okay, so 20 ml, and then you give slowly over maybe 10 to 20 ml, preferably slowly. Okay, because the patient can vomit sometimes or maybe feel very severely, nauseated, and she may feel warm also. Okay. Suppose now for IM you said directly 5 gram, that is 5 ampoules on each buttock. So that is total of 14 gram of loading dose. How do you monitor? What are the parameters?
We have to monitor three important parameters. One is respiratory rate, patellar reflex, and the urinary output, because it causes the respiratory depression and neuromuscular depression also, and because it is excreted from the renal, from the kidney. The kidney function is very important. If the kidney is not functioning well, then there will be accumulation of magnesium and causing magnesium toxicity. So the three important things are respiratory rate, patellar reflexes, and urinary output. Respiratory rate, at least it should be more, it should not be more than 14. You can assume it as less than 16 per minute. And patellar reflexes have to be present. If it is absent, then we have to withhold this one. And urinary output 30 ml per hour, or over the 4 hours it should be at least more than 100 ml per hour.
Yeah. So what I ask you is, suppose you are monitoring this patient very carefully and you find that next dose is due and the patellar reflex is absent, then what do you do?
Yeah, ma'am. Then we have to stop the dose, withhold the dose, and
that particular dose, correct?
Skip the dose.
We don't have to discontinue the regime, but we have to just keep that particular dose, correct?
Yes, ma'am.
Suppose you have the urine output which is less than 25 ml per hour also, then what do you do?
Urine output, ma'am, we whenever the urine output is less, then we check for the creatinine level, and if accordingly we can adjust the magnesium sulfate dose. If it is severely compromised, we have to withhold it. If it is not so, we can adjust and reduce the dose, ma'am.
Right. And if it is still further severity, then suppose your patient lands up into magnesium toxicity, suppose even the patellar reflex is absent, and even the urine output is less. Now this is a time that she can go into, respiratory problems, respiratory
We will
paralysis.
be checking
So,
the saturation level
huh.
and
Suppose
oxygen
you don't have the facilities, but you are having this clinical acumen, right? That your patellar reflex is absent and you have the evidence that her urine output is definitely less. Then what will you do?
Yeah, we stop the magnesium sulfate dosage.
Yes, and
we check for the serum
Give
magnesium
calcium
level.
gluconate.
Give
And
calcium gluconate, right?
calcium
How
gluconate.
much and how?
Calcium gluconate in the dosage of 1 gram per 1 gram, which comes in 10 ml. Over 10 minutes we have to give.
10 gram in 10 ml, right?
10 gram and 10 ml.
10%, right?
10%.
In over 10 minutes.
Over 10 minutes.
Correct. Give it very slowly, but you have to, start a ECG monitoring for this, right?
Yep.
You have to have a monitor for this. Okay,
Yes.
so that is how. Now, which regime you prefer? You said pre-charge regime. All of us, even today till now, we are using a pre-charge Maxwell regime. That is definitely you continue it for how many hours?
We have to continue it for
24 hours?
Yeah, 24 hours after the delivery.
Delivery or the last conversion, whichever is later. That is what is the clause. Right? Okay. So my message to all of the attendees is that whether it is prophylactic, whether it is therapeutic, that means whether you give it before the patient convulses or you start it after she has convulsed, you have to continue this regime in this standard pattern and the standard dosage up to 24 hours, right? After the delivery or after the last conversion. That is what is the basic of this. Even though it is called as prophylactic is only to prevent the eclampsia, right? But then once you start it, you have to give it over 24 hours. Now, what is Duspan's regime? And whether which helps in neonatal neuroprotection also, the fetal neuroprotection. Yes. Duspan's regime.
Duspan regimen, it is given IV, ma'am. We give IV.
Huh.
Usually, whenever the platelet count is very less and we have a chances of bleeding tendency, or in West also they prefer giving Zuspan regimen. Here 4 grams is given initially loading dose.
The similar one, correct?
Yeah.
Initially similar, and then you give it as 1 gram per hour. That is 500 gram in 500. 1 pint you add 5 ampoules. That is 1 gram per hour. So you give 100 ml per hour. Okay.
Yes.
So only problem with this is suppose the patient is severely edematous. She has waterlogging. Okay. So you are giving lots of fluids here. See, in addition, you are giving the maybe around 5 pints of fluids. Correct?
Ma'am.
Correct?
Yes, ma'am.
So
Yes.
5 to 6 pints of fluids additionally. So when you want to go for fluid restriction, you have that preparation IV mag which is available nowadays, and that also has 4 gram in 100 ml. Okay, 4 gram magnesium sulfate. It is available in 100 ml of normal saline. Correct? So you give 25 ml per hour. That is how you have to give it very slowly. And of course, everything is similar. And this is the same regime which we are using as Duspan regime is useful for the neuroprotection because we want to continue this also with for 24 hours. So whether you use magnesium, the pre-charge regime or you use the Duspan regime, there is no compulsion from anybody. Whatever you are comfortable with, whatever you are well versed with, I think you should go ahead with this. The only idea is to continue it for 24 hours. Correct. So, Dr. Anita, I would ask you, how often do you repeat the investigations and at what age, gestational age, you would like to deliver her?
Again, it's severe preeclampsia, severe hypertension and non-severe hypertension. With non-severe hypertension,
No, our same patient. She has developed already severe hypertension. Yeah. We are having only one case and we are discussing, we are taking her ahead. She was, initially non-severe, but then she developed severe hypertension. Then we managed her, then we tried to stabilize her. Now we have given her maybe we have stabilized her. Okay. Now, how do you want to take her forward? And when do you want to deliver? That also we have said that we want to take her ahead. But suppose she develops, maternal problems, complications, or she develops some fetal indications, then you have to deliver her. Okay. So meanwhile, how frequently do you want to investigate her?
So investigations every yes,
yes, please go ahead.
Bi-weekly we have to get her investigated. By every third day we have to get her investigations weekly.
Yes. If she has
If it is
not much of
controlled.
significant impairment in the liver or renal functions, maybe every third day. But if she has severe impairment, every 24 hours,
then every
even
24 hours
12
we have to repeat the.
Correct.
Yes, ma'am.
Yeah. So we have talked
then-
about this. Yes. Yes. Go ahead, please.
Yes, and in any as far as possible, we want to take her up to 38 weeks of gestation. If she is not
34.
developing any of the end organ
34.
damage,
We can't
if
take
she
her.
has developed, sorry, 34 weeks of gestation, till the fetus achieves lung maturity.
Yes.
If she develops any time in between this, if she develops any indication, we get an indication to terminate the pregnancy, then we have to go ahead with the termination.
Correct. Now,
suppose that gestational
suppose she is, landing up into complication, you need to deliver her. But suppose her cervix is not favorable and, the fetus is compromised. So you have to take her up for cesarean section. So what type of anesthesia you would like to have, and how do you manage it? What preload, afterload, what medications you have to take care of? Dr. Vidyashri, you can take up this question now, and then Dr. Nivedita, we will go ahead.
Yes, madam. So since in this patient already since the intravascular compromise is there because of extravasation of the fluid, but we need to be very careful about the preload of fluid here, because preload again might trigger cardiac failure or pulmonary edema.
Pulmonary edema, right.
So we need to monitor the urine output and maintain the lowest whatever the 75 ml per hour or 50 ml per hour of fluid.
Correct.
And then so if the urine output is adequate, even with that should be that amount of fluid will be enough for that patient.
Okay.
So we should be very careful about how much fluid we push into the intravascular space.
Yes.
Because that can cause an adverse reaction if it is not under control.
Okay.
So the type of anesthesia that we would prefer here would be spinal anesthesia.
Yeah, regional anesthesia preferably.
Regional anesthesia preferably.
More than spinal, I think we should say
epidural would be the first choice. But considering the time that it would take for the action, spinal anesthesia would be the
because
choice.
there is no emergency, no. We are just trying to deliver her because she will not be able to go ahead. We can't take her ahead, right?
If at all, if there is a fetal compromise, madam.
Yes.
If fetus is associated with fetal compromise, then whatever fastest way we would plan that.
Yeah. So actually this patient we decided to, because she's landing up into complications, developing very severe hypertension, and so we decided to deliver her. But then by the time you decided, she started getting very severe pain in abdomen, headache, and when you examine, you find that her pulse rate is 100, blood pressure is again 170 by 110. In spite of all your antihypertensives, the uterus is tense, tender, fetal parts, they are not well fed because it is tense. And fetal heart is 110, so it is fetal distress. Okay. So there is little bleeding also. The os is only 2 finger lows, not favorable. Station is high. So what has gone wrong here, and what investigation? Yes.
There is an abruption, probably, madam.
Yes. How do you confirm that?
So we can confirm either by doing an ARM. Or even by doing an ultrasound, if we see a retroplacental clot, that will confirm, or fresh frank bleed when we do an ARM, or while doing a cesarean section, closed placental clot also will confirm.
But then because it is only 2 finger lows, do you really want to go for ARM? She's not going to deliver, but then
So,
you.
yes, madam. If at all, if there is a facility of bedside ultrasonography would be more helpful.
Right.
But the
Right.
posterior placenta, again, it might be a little difficult to identify if there is a retroplacental bleed.
Okay, so this patient was, subjected to ultrasound. It was 33 to 34 weeks now by this time. RP clot of 200 ml, fetal heart is 100. Now, coagulation profile, was sent in meanwhile, and platelet count is 50,000. BTCT is approximately, apparently normal, but fibrinogen was only 150 and FDP was present. How would you proceed? On one side, you have fetal stress, on the other side, you have maternal, coagulation failure. So whether you want to, yeah, please
Yes,
go
ma'am.
ahead.
So in this case, emergency, considering the fetal and maternal complication, it's a double-edged sword here, because if you want to save the baby, then we'll have to go ahead with cesarean section. But if you are not considering the fetal outcome, then we can still give a chance of vaginal delivery in this patient.
But then you have to work optimum, no? See, 33 to 34 weeks baby, do you want to really lose it?
So yes, madam.
Simultaneously, I would
Yes,
say,
madam.
right?
So yes, madam. Considering the fetal outcome as well, so in this case, we'll have to prefer doing a cesarean section. So considering the platelet count being 50,000, anesthetist would definitely will not be willing to give
50,000 is good enough, my dear. 50,000 is
But,
good. The FDP is present, fibrinogen 150,
and
but
platelets.
DIC has definitely set in. So what you have to do is arrange for blood and blood
Blood
components,
and blood
whatever
products.
is
Yes,
available,
madam.
maybe the
Start.
cryoprecipitate, maybe FFP, whatever you have in your hand, you order for it and start
Start
infusing,
the transfusion.
transfusing.
And
By the
yes, ma'am.
time you deliver the baby, okay, and
Yes.
try for few more blood and blood components. Now, my question is, what oxytocin? It's not all. Just because you deliver the baby and you remove the placenta and RP clots, that's not all. The DIC is already set in. Also, this is the same patient who is going to bleed profusely postpartum. So, what what oxytocin you want to use? What all drugs you want to add here?
So the initial the drug oxytocin will be used, madam. So in case if we see that the oxytocin is
for this patient, do we have some option?
we can use misoprostol as well as even prostadine can be used, madam.
Because she's severe hypertensive, we have carbetocin.
Carbetocin, yes. Carbetocin, yes.
Anybody else? I can hear some Dr. Vidya's voice, is it? No. So we have carbetocin, which is a very, very effective oxytocin. Single dose can take care of oxytocin, which is, required for maybe 8 to 16 hours. So that is why if you give it prophylactically, it works. Once, you use oxytocin and then you give as a treatment, carbetocin doesn't work. Okay. So if you give carbetocin as a first drug of choice, then definitely it will work. And then, of course, you can continue with the other modalities also. You can put in per-rectal misoprostol, or if at all you feel that, hypertension we can manage later on, but then we have to control this bleeding first. So in that case, so definitely the packing of the uterus and massaging the uterus, and of course, injection carboprost also, if needed, because PPH you have to stop first, right? So all these things you have to keep it in mind, definitely. So already we have discussed about this anesthesia. This is the DIC score, which theoretical discussion I don't want to go, but you have to consider that platelet count, elevated fibrinogen degradation product, prothrombin time, and fibrinogen. These are the parameters which you have to consider. You score it as score of 5. If it is more than 5, it is over DIC, and if it is less than 5, it is non-over DIC. So you have to repeat the score in 1 to 2 days. That is for the early DIC when it is not set in actually. But our patient has already set in. So, you have to confirm that the fetus is alive before taking a patient for cesarean section. And then you go for the cesarean section. But now, while taking the decision for the cesarean section, the patient, she had persistent severe headache in spite of Maxelf, in spite of antihypertensives. It did not, got relieved. And that is the reason she was subjected to MRI. So just before the cesarean section, but then on the way to MRI she convulsed, and then when the MRI was done, this was the picture. Okay, so this is high signal intensity bilaterally parieto-occipital white matter consistent with the vasogenic edema, that is the posterior reversible encephalopathy syndrome. Yes. Correct. So this is just a, it's a fancy thing. Definitely you don't have, you can't prevent it, and there is no definitive treatment. Only you have to keep a watch. Don't allow your patient to become a severe hypertension from a non-severe hypertension. That is what is our responsibility. So of course, IV mannitol, IV dexamethasone, whatever, you can do. This is the only thing which we should feel happy is it is a self-limiting or self-restricted entity, and over a period of 1 week. If it is purely press, then with all your supportive measures and continuation of the treatment, the patient recovers over a period of 1 to 2 weeks. That is what is the happy part about it. So you use any agent, it's not going to, work. So friends, a crisis is integral to human life, and those who timely and appropriately counteract it will survive and succeed. And that is what we have to do as obstetrician. We have to be very vigilant. We have to, don't wait for the crisis to happen. In fact, I would say you predict, you foresee what is going to happen. Try to prevent it. Use whatever preventive measures you have, and definitely at the earliest, whenever you feel that yes, it is happening, you timely and appropriately manage it. That is what is the take-home message that we have, the predictive factors as HDP gestosis score, and then we have the biophysical and biochemical test, which can actually guide you, predict the hypertensive disorders. You can actually, now you have the severe and non-severe, even with 140/90, you feel the BP is mildly elevated. You can go ahead with the laboratory investigation, go for the alarming symptoms and signs you look for, and then you categorize as severe or non-severe, and you manage accordingly. You have the best of the antihypertensives, even orally and intravenously. That is how we can definitely have this prevent the complications and reduce the maternal mortality, I would say. With this, before I thank all of you, I just make an humble appeal to support my candidature as Foxy Vice President from West Zone. West Zone being very big, we have 6 states, so we have 2 posts for Vice President, and I request you to keep me as your first choice for the Vice President Foxy from West Zone. Please do vote for me in the month of August, that is from 1st to 10th August. The voting is online, and it's going to take only 1 or 2 minutes of your valuable time. So it's my request once again, and I thank all of you for being actively participating in this panel discussion. The panelists are very, very well read and well experienced. So I'm very happy to have the discussion with all of you, and I thank all of you. Also, let me take this opportunity to thank the entire KSOGA office bearers, especially Dr. Bharti Rajsekar in particular. Actually, I said twice, actually, Dr. Vidya Thobi, thank her, but I think we don't have her on board. If you can see Dr. Sonia, please.
I think she had some network issues, ma'am.
Okay. So otherwise we could have had the closing remarks or concluding remarks from her, the expert comments, but I don't see. So I think we conclude our discussion here, and I thank all of you once again. Thank you so much, Dr. Sonia and Dr.
Before we conclude, I should acknowledge the fact that you've been so vibrant, taking issues from the basics. I also take this opportunity, as Dr. Vidya Thobi is not here in this virtual platform. I should make a mention that from the basics to the post-delivery facts, which is to be recognized on a day-to-day practice, was well discussed in this panel. Yes, when we were postgraduates, it was like only methyl dopa. That was it. Any viva was here, any questions was that it was methyl dopa. Over a period of time, we have come to IV labetalol. That was the journey, as you rightly said, that we have been practicing like that. But the updates are very, very much needed. And your one slide said that urgency and emergency. That was very catchy, ma'am. And we are doing drills for all postgraduates and the nursing staffs where we are sensitizing them how exactly they should counter a patient with preeclampsia as well as eclampsia. As all the panelists have put it across, it is 4 grams loading dose. We always teach them 5 right buttock, 5 left buttock, and 4 like this. So it's very easy to remember. 5 like this and 5 like this, intramuscular, and 4 like this. And after which the maintenance is just 10. 10% calcium gluconate, 10 and then 10 minutes. So it's a very easy catch to make the other nursing staffs also sensitized about the fact till we reach that there should not be any miss on the treatment modality. With this and post-delivery, we have to see to that we ask them and monitor them at least for a week's time with the mind of pressing our mind and then waiting, not for the press to happen anymore. With this, I also request and I also take comments from Sneha ma'am that every case sheet, on the case sheet, if it is HDP, please we make a note of justosis scoring so that any other consultant who's on duty, it's easy for them to recognize the case. So with this, it was an excellent panel. And I don't think so. Dr. Uma is still on this virtual platform. Is Dr. Uma there?
I can see Dr. Rupa Prakash.
Hello.
Yes.
Hello, I am here. Thank you very much.
Madam, I had one question before we conclude. And this is regarding the midstream urine sample culturing in antenatal cases.
That is for you went to culture.
Asymptomatic bacteria.
Always
asymptomatic bacteria. Yes.
Asymptomatic bacteriuria. When we'll give the sample, always for culture we have to give midstream urine. What do you want to ask about this?
In your daily practice, you made it a routine, ma'am?
No. Now I have seen with the. It is not recommended. Actually, it is routinely. It is not recommended. If any the IUGR are there, the height is less, and we are suspecting, then only we have to go this investigate.
I would
routine recommendation is not there actually.
Because you know.
No, but I think
it is context specific recommendation.
That is probably okay with the WHO recommendation, but in our practice, routinely a urine culture with a midstream sample is done, and asymptomatic bacteria is picked up and treated.
Yes, that is what I wanted to say, that in fact you should do it, because you know, even when you examine the urine, no, otherwise when you collect, it is always recommended that whenever you collect the sample, it's a routine process that you clean, but not to use any antiseptic or vaginal wash. It is just cleaning with the plain water, and then you go for collecting the midstream urine sample, that so that you don't have the contamination of vagina and the bacteria which are already there. So that is what is the routine method of collecting a sample. That is what
I actually brought this question into notice because we've seen 20 to 30% of false positive reporting, only because we are not explaining a proper collection technique for our patients.
Yes.
That
is what I am saying. Whenever it is urine sample, it is always a midstream urine sample. With a routine cleaning.
Routinely for not only for the pregnancy. Whenever we'll give the urine for culture sensitivity, we have to give midstream only. Post delivery, anytime before pregnancy, if you are suspecting for a UTI, for when the patient comes a honeymoon cystitis, they will come. No, whenever we'll send for a urine culture, we have to take the sample of midstream. We have to explain them how to give the sample. As Madam said, they should not use the this one before giving the sample and septic lotions.
Thank you very much, ma'am. Thank you.
Madam, your panel discussion was wonderful. Your panel discussion was wonderful. And the way you emphasized that we should treat hypertension at 149K was wonderful. And this message needs to be conveyed.
Yes.
It has to be conveyed. And the way you took along with the nifedipine, the sustained release tablet, the capsule, labetalol was really wonderful. And the only thing that I find in my day-to-day practice is that most patients don't tolerate nifedipine because of severe persistent headache because of vasodilatation.
Yes.
Which
In fact,
labetalol does not cause.
That is why we are saying that why labetalol? That is what the question was.
Yes.
Why labetalol is the first drug of choice? Because it has got a dual action mechanism, the alpha 1 and beta as well. So it is not only antihypertensive, not only the peripheral resistance is reduced and there is vasodilated, but it is also the cardiac effects like alpha methyl dopa and like nifedipine. That is what is the mention here. So I think
what is your idea about digital BP monitoring by patient herself at home when patient has mild
or it is digital.
Ma'am, actually, digital
digital. I think it has to be carried. If it is just a market preparation.
I think, madam,
your net is not working. Low signals.
Dr. Hemlata, you wanted to add on something? Voicing out?
Digital pigment.
Whenever you want to, the first question I asked Dr. Anita, no, whether you will label her as hypertensive. There comes the, the ideal way of taking blood pressure measurement. There you have actually the patient has to be mentally and physically relaxed. Should be empty, clothing should be comfortable. Per arm, you have to measure a blood pressure. Maybe sometimes.
Somebody has to mute themselves.
Of course, it is a medially.
Yes. Madam, I think you have a bad signal at your end. So we were not audible. Sneha, ma'am? Okay. I think, Anita, we are having a lot of network issues everywhere because of the bad weather.
Sonia, ma'am?
Yes, ma'am. Yes, ma'am.
Okay. Ma'am, you're back. Yes.
Can I conclude?
Sonia, ma'am?
Yeah.
Anita?
Yes, ma'am. Yes, Nivedita, ma'am, here.
Idu neuroprotection, is it the Pritchard regimen only? I just want to confirm it. Neuroprotection.
It could be either. Nowadays, we are not using Pritchards. We are always with span now. So if you are comfortable with your Pritchards, you could use that. It's the same regime.
Same regime.
As long as the molecule.
But people in Bellary who have a lot of case of eclampsia have come out with low dose Maxel. They advise only 2 grams. 2 grams single dose. But for neuroprotection, you give it for a longer time. 24 hours.
For neuroprotection is actually accepted by the Pediatric Society as well.
Yes.
So I think the molecule matters a lot. And the maintenance for 24 hours. Okay, I think...
If you wait for 24 hours when steroid is being given. So along with that, Maxel is also given. So it will help you with both CNS and RS.
Okay. Thank you.
Okay. Thank you, Rupa ma'am. As usual, an excellent teacher. And Nivedita, Anita, and all the others in this virtual platform, I should tell that I'm blessed because she has also been my teacher. and a mentor too. And our Mysore OBG Society last year did amazingly well. And next August, we all will meet with the chairperson for scientific committee as Dr. Rupa Prakash will take us along with an extensive bonanza of good topics. We look forward to meet you all in Mysore. With that, over to you, Dr. Anita. Could we conclude?
Thank you, ma'am. Next session today evening. We will conclude the session. I would like to thank AMOGS Emergency Obstetric Committee with KSOGA for this wonderful session. I thank Dr. M.G. Hiremat sir, Chief Patron KSOGA, H. Nagaraj sir, Patron KSOGA, Bharti Rashekar ma'am, President KSOGA, Vidya Tabbe ma'am, past President KSOGA, Dr. Rajeshri Paradi ma'am, who is Secretary of KSOGA, Suma Reddy ma'am, the Treasurer, and also Dr. Durgadas Arsana sir, President elect KSOGA. Special thanks to the office bearer as well, Dr. Kiran Kurkoti sir, President AMOGS, Dr. Bipin Pandit sir, Secretary General AMOGS, Dr. Rajesh Singh sir, IPP AMOGS, and Dr. Madhuri ma'am, who is Treasurer AMOGS. Special thanks.
Okay. Today we are having a lot of issues with the network. I think I continue to thank the technical team in spite of all the problems with the weather. Yeah.
I thank Dr. Sneha Bhuyan ma'am and the best for her actions. M.D. Hiremat sir and Dr. C.N. Purandre sir, who were the chief guests for today's webinar. I think the network issue is going on. I thank Dr. Suvarna ma'am and Dr. Madhuri Patel ma'am for the guest of honor. I thank Dr. Uma Deshmukh ma'am for a wonderful and yet important topic. And Chairpersons, Dr. Rekha Rajendra Kumar ma'am and Dr. Prakash ma'am. A wonderful panel discussion starting from a single case and making it reach up and till the ICU, because it's the most common scenario we usually land up. So this thank you Dr. Sneha ma'am for that, and Dr. Vidya Tabbe ma'am being the expert. I thank all the panelists, Dr. Soumya Patil, Dr. Nivedita Bhavi ma'am, Dr. Vidyashri, Dr. Rameshwari, Dr. Hemalata CR ma'am. And
okay, thank you, Anita.